Chapter 15, Gonorrhea in Women, by Dr. E. D. Behringer. There is probably no infection which appears in a greater variety of forms to tax the skill and judgment of the medical practitioner than gonorrheal infection in the female. Its almost infinite variety of clinical pictures, its frequently obscure onset, its insidious progress make it often difficult of diagnosis. Again, the sociologic questions which accompany this infection still further complicate the problem of treatment. It is of importance to consider some of the causes which have combined to make this infection in the female sex so much more of an elusive factor to deal with than in the male. Foremost of these is the actual anatomical difference in the conformation of the genitourinary organs of the two sexes. In the female, the extent of mucous membrane which may be involved is enormous in comparison with the male. The vulva with its intricate folds, the urethral orifice with its glands, the vagina and cervix around which the gonococci are usually deposited, the uterus with its endometrium rich in glands, the fallopian tubes, the ovaries, to the peritoneum, present one continuous trail for gonorrheal invasion. Again, as this disease practically always results from sexual intercourse and frequently from illicit intercourse, the question of gonorrhea has gone hand in hand with the history of prostitution. The sociologic problems surrounding prostitution are necessarily intricate. Man and woman hold entirely different positions in regard to it. The man who transgresses has but little thought other than perhaps a preliminary burning of conscience of the moral side of the transgression. His one thought is to seek consultation in order to rid himself of the disease, and when cured, he is no better nor worse than the small percentage of his fellows who have not transgressed. He belongs to the majority. On the other hand, the woman who transgresses is an outcast. Her one thought is neither to seek advice nor consultation, but to hide everything. The causes for these 2 points of view are probably on the one hand man's aggressive nature, his ability to create public opinion, and on the other hand woman's passive acquiescence to these created standards. It is this man who has transgressed, who has had experience, who marries. Therefore, when any question of gonorrheal infection comes up after marriage, his experience is pitted against his wife's ignorance in disguising the real condition of affairs. And if strange and overwhelming disease comes to the woman after marriage, not realizing what causes might be responsible, she has been taught to believe that this suffering is woman's portion and has accepted her lot. That woman is monogamous by instinct has not a little to do with this point of view. Not so with the man. If he has reason to believe he may have gonorrhea, at the outset of the first symptoms, he consults a physician, and the physician must be ready with prompt and efficacious treatment if he would hold this patient. Out of this situation have arisen numerous methods or schools of treating acute gonorrhea in the male, and this treatment has reached a stage of great perfection because the demand for such treatment has been insistent. With his female patients, the physician has been put under no such pressure for diagnosis, and while he has achieved lasting fame in the treatment of the later surgical complications of gonorrhea in the female, he has often gone in the line of least resistance in making a diagnosis of gonorrhea in its early stages. The woman, not suspecting what may be at the bottom of her slight indisposition, has too often been reassured by the statement, "Oh, the discharge is only the result of marriage relations. You have taken a slight cold in your bladder," etc. She goes home and neglects herself and returns to her physician only when symptoms have sufficiently asserted themselves so that he can make a clinical diagnosis of gonorrhea. As a result, many a case of acute gonorrhea in the female is grossly mishandled and swells the list of those cases later demanding surgical skill. When, therefore, the possible gonorrheic presents herself for consultation, the conscientious examiner must tactfully approach his task and attempt to find out in which one of the following classifications this particular woman belongs. First, is she a married woman? who has innocently contracted the disease, knowing nothing of its nature? If so, the economic question of not destroying the marriage relation presents itself. Second, is she an unmarried woman who has contracted the disease as a result of illicit intercourse? If so, is she a, quote, first offender, unaware of the enormity of what she has done, or is she a prostitute? Third, is she an unmarried woman who is quite innocent of any sexual relations and has had the misfortune to contract the disease by the use of infected linen, toilets, douche outfits, or dirty instrumentation? Fourth, is she perhaps one of the victims of a former infant gonorrhea? Fifth, if the patient be a little girl, has she become infected from some unrecognized source in her own family? The importance of a correct diagnosis at once becomes apparent. 1, for the safety of the family or community. If the innocent woman is infected, she must be instructed how to take care of herself, as she may infect other members of her family or her own eyes. If the patient be a prostitute, she must be warned that she is in an infectious state. 2, in justice to the individual, it is only necessary to mention how important it is to know what germ is responsible for the infection. It may mean the ruin of an innocent woman's life to be labeled gonorrheic when an entirely different cause could be found on investigation. 3, for the purpose of intelligent treatment and prognosis.